welcome everyone to the board of NHS Direct, NHS Trust. Welcome, Dave. Today is the first board meeting we've had since our short summer break, although the board has met together in seminar form since then. So I think our agenda today is a relatively standard one, not necessarily expecting many surprises. There is one, there are no apologies for absence, which is nice. Oh, there is one apology. Oh, I'm sorry, I'm looking at the wrong agenda, of course. So we're welcoming Dave, who's standing in for Ruth today. I would also like to make an announcement, which isn't news to anybody in the room. You recall that Trevor Jones, our long-time Deputy Chair, retired earlier in the year on the 1st of July. And although I would like to think that Trevor's maybe watching us online now, I suspect he may have a more pressing engagement. So without a Deputy Chair, we needed to replace somebody to replace Trevor in that role. And I spoke to a number of colleagues, and the conclusion we reached was that Sue Hunt was the right person to be the Deputy Chair from now on, which is, I think, a fantastic choice. Sue's going to do a brilliant job. She's got a fantastic track record with us at NHS Direct and also does lots of other exciting things. So I think my impression is that everybody is very happy with that choice.
Yes.
So congratulations, Sue. Moving on to the agenda for today, we don't have any declarations of interest. If anybody would like to make one now, they're very welcome. If not, we have two sets of minutes to look at. We've got both from the 29th of July. We have our AGM minutes and then the board. Let's just take those one at a time. Are there any matters of accuracy on the AGM minutes? Okay, I'll take them as an accurate record then. And there aren't any particular matters arising or actions from those. Let's just move then on to the minutes of the main board meeting on the 29th of July. Are there any matters of accuracy on those? Tricia.
Yes, Chair. Point 6.1.7 on the third page of the minutes. The board was pleased to note the trust is achieving its targets of 95%, receiving 3 or more core reviews. I'd like to correct that to the trust is predicting we would be achieving 95% of staff receiving 3 core reviews. And that's correct for August and September.
Okay, that's good. So there's a clarification in the minutes. Thank you, Tricia. Any other matter of accuracy on those minutes? No? Fine. Let's look at the action log, which is gratifyingly short.
I think the only issue is the one about follow-up on action plans arising out of complaints, and we can either deal with it now, or we can have done with the performance just on the scorecard, whichever.
Let's do it now.
Do it now. So, Tricia, where have we got to in terms of getting ourselves back into a position where we are achieving 90% or more of complaint follow-ups within the relevant timescale?
We've made significant progress in addressing the backlog. The majority of it, as I reported to the board at our last meeting, the immediate actions where there is high risk to the organisation or a high priority is addressed immediately. This is issues related to training and people often upskilling. So we've done a significant data cleanse with Chris's support through operations. Team managers have now been targeted to close down their actions and ensure that staff members have completed the learning that needs to take place. And we are in the upper 70s, early 80s of our progress. So we hope by the end of October we will have completed that and be on target.
Thanks, Tricia.
Because the scorecard percentage that's reported for August is at 57% for 111.
Yeah, and we've made further progress.
We've made progress since then.
September.
Okay,
Yeah.
I just clarified. Yeah.
Thank you. I mean, I think none of us were surprised that there would be a hump of feedback and issues for a new service. And the important thing, which is you stressed last time and then again today, is that anything which has an urgent, important clinical consequence is addressed very quickly. And there's a tail of things. So,
Correct.
Thank you very much. That's very reassuring. Okay. Then I think we're able just to move on, Nick, to your Chief Executive's report, which is categorised in the performance section of the agenda.
Which is mercifully brief. The first thing to say is that we are continuing with the 0845 service, which is now running at about between 12 and 15% of its previous volumes. And NHS England have now asked us to extend that to the end of February, but at an even lower level, between 2.5 and 7.5% of historic volumes. And we're just in the final stages of agreeing that with NHS England. As you get smaller, the challenges become greater, perversely. So that, for example, if you had a relatively small number of staff who didn't turn up unexpectedly, suddenly you have a big gap, and therefore the service is a bit more subject to fluctuations, and that's one of the things that we're talking to NHS England about.
I would just interject there and say that's not the worst at all. I mean, that's exactly what we've been saying in relation to a whole lot of things.
Yes,
size, stability, ability to resilience, ability to withstand.
Yeah.
So what we're saying is that as we contract, that volatility becomes, the volatility gets higher.
So small is not beautiful in this particular instance. It is reverse. So the second is that, as the board are very well aware, we are in progress of transferring all of our 111 services to alternative providers, and these are listed in my report. And as part of that, we are also transferring the staff in Middlebrook, Carlisle, Dudley, Beckenham and Exeter under cheapy transfers to ambulance trust providers, together with the call centres, and that we will be seconding our permanent staff at Milton Keynes for a temporary period of time to South Central Ambulance Trust. But essentially, we're ensuring that all of the 111 services which are currently operating at good performance levels are handed over to the ambulance trusts in accordance with a plan that's being overseen by NHS England, and all of those transfers are due to take place between the end of October and the 19th of November. So clearly that's an issue that we are keeping close in touch with both ambulance trust colleagues through 5 separate project teams, and with local commissioners through Dave and his regional director colleagues, and with NHS England on a day-by-day basis. And the objective is to make sure that the transfers are as if nothing happened. We simply carry on providing the services in a nice, regular and continuous way during the period of transfer.
And we'll be hearing more about the what's going on behind the scenes in the private section of the agenda in the transition and decommissioning report from Roger.
Yes. Okay, and then the final item is, again, the board will be aware, but wants to make sure it was in the public domain. We are now in discussion with the NHS Trust Development Authority, with the Department of Health and NHS England and other organisations about the implications of those transfers of the 111 services for the future of NHS directors and independent organisation. And whilst there's nothing to report at this stage in terms of firm conclusions, I wanted the fact that those discussions are occurring to be in the public domain, because clearly we are. It's important that we maintain the confidence of our staff by continuing to provide them with good, clear information that they can rely on, and that's why I'm ensuring that it's in the public domain, because we work to the protocol that if there's anything we are telling our staff, we are also telling the public.
Thanks, Nick. I mean, I guess what I take away from this report and everything that's been going on over the last few weeks is the absolute imperative top priority of smooth transfer of services, and that the longer that this organisation is responsible for delivering frontline services as volumes go down, the more fragile it is. And given that through this entire process, patient safety and clinical quality has been our top priority, we become more anxious about that the longer time goes on. So that's the context, I think, in which you need to be seeing everything that we're doing as a board. Are there any questions or comments for Nick on his report? Okay, thank you. That was very helpful update, Nick. We then move on to our corporate performance package, which I will look to Jackie to navigate us through. I have my version for the visually impaired in front of me.
That's a good idea.
I only have a smaller version, but hopefully I can see it adequately.
I'm sure you know it.
Focus on the rest of it.
I think it's fair to say that we're continuing to deliver a good level of performance on all services, particularly for non-clinical access. Clinical access is improving for both warm transfers and callbacks and 10 minutes for 111 services. But as we've said earlier, volumes remain relatively low for all services. In terms of the areas of concern, the ones with the red rating, they are the same as they have been for the last couple of months, although we are seeing some improvements. We talked earlier about the actions arising from complaint action plans. We've already covered that one. Staff receiving more than 3 reviews. That is improving, but not yet reached the target of 95%. Callbacks within 10 minutes again is improving, but still not reached, and I don't think we will ever reach the target of 98%. Nurse average handling time is 727 for the month, against a target of 690. However, within the budget we had a target of 730, so we are within the budgeted average.
Let's not call that a target.
No.
We have a ceiling.
A ceiling of, okay. And then the number of staff on long-term sick remains in red, as does the year-to-date deficit, which will probably remain in red for the rest of the year as well.
Can we just pause there for a second, Jackie? I think, Tricia, you wanted a point of clarification.
Yeah, just to remind board members that for August and September, because this data is for July, so for core reviews, for both parts of our service, for the DHAS and for the NHS 111 services, all staff have had 3 core reviews.
Okay, it is actually
It is July for core reviews because it's a month behind.
It's all right.
Just a little.
Thank you. That's
just
helpful.
a little.
A quirky bit.
So your run rate is where it should be?
Yes, absolutely. We are on target
As
for
of
August
now.
and September.
We're going to pick up.
I just wanted to pick up long-term staff sickness and key Roger in to say a few words. This is of concern because the number of staff that we employ has come down substantially, and this number here is the absolute number of staff who have had a period of continuous sickness for 1 month or more. So it is of concern that the number is. So if you express this in percentage terms, it's increased substantially, and the way that we've approached this is that this is a potential hazard for staff, that the period of change that we're going through and the degree of stress that is causing to members of staff is of concern, and therefore this is something that we are not sitting back and either regarding as somehow blameworthy absenteeism, nor simply something that is another number. This is a major concern, so we are progressing action to support staff, which Roger may be able to say a brief bit about.
Yes, I can. It is worth just prefacing what I'm going to say by the fact that short-term sickness, interestingly, has remained almost at its target, and that isn't an absolute number, that's an average, so that is the sort of that remains a good result. If you remember, our days per person sick per year was up at sort of 17-18 at one point and is down to 13.4, so that's just over target. So we've managed to maintain that's standard. But as Nick says, the long-term sick is worrying. We've done a bit of work on it. We are not able to identify any trends in groups of staff or in sites. So the two highest long-term sick sites, one is a 111 site, one is a digital health and advice site. So we're not able to pick anything up that, but not surprisingly, by far the most common reason is stress and anxiety. So we're approaching our solution to this on a sort of twin track, really. The first is that we are reintroducing the colleague support. We've had to re-procure because the 1080 work kind of run out, but we've re-procured that for a limited period of time. But equally importantly, there is in our contract with Right Core Care, our occupational health provider, a personal counselling service. So we're going to do a campaign, a leaflet, poster, intranet and news shop campaign on the fact that that is available and people can anonymously get 6 sessions of counselling through that. And the campaign is an acknowledgement of the changes people are going through and urging people to get some help before they become sick. So that's what we're doing. It's fairly straightforward. It's not that sophisticated, and it's probably just about all we can do given the circumstances we've got at the moment.
Steve, did you want to?
Just to give us, I just would welcome a sense of the point that Nick made in terms of that this number's going up as full-time equivalent's going down. Can you give us some sort of
Probably doubled.
It's doubled.
I would say, as a rough rule of thumb, it's about double what it was. If you regard it as a run rate per whole-time equivalent.
In that we have about half the employees that we had a year.
And this is roughly the same number as last year. In absolute terms.
That's quite worrying.
It is absolutely. It's worrying. Absolutely, it is.
The other thing that it makes me realise is that we don't, in all of our performance package, what we don't have is that overall picture of the organisation in quite that sort of way. Do we?
I suspect that Jackie's report has got the full-time equivalent numbers in it.
Yeah, no, I was just thinking about seeing the trajectory of our staff complement today and projected.
You had it in
split between our staff and agency.
It's on page 7 of 9 in Jackie's report. Frontline staffing and non-frontline staffing full-time equivalents.
And you had it in the July.
Yeah, no, what it doesn't have is it doesn't have the.
This is the plan.
Okay, fine. It's got exactly what I wanted. Thank you.
And this is all our staff, isn't it? None of it's agency.
No, it's our staff. Yeah. And it leapt. I mean, it went up fairly quickly from June to July, and it stayed fairly high in long-term sick. So it went up. So it was a sort of. We went through a lot of change. There was then a sort of pause, end of May, June. And you're left with, in the organisation, half the people you had before, and they're anticipating a lot more change.
Yes.
So it's. I don't think it's that surprising. I think it's important that we respond to it.
Yeah. Does it hazard our ability to deliver the 0845 extension, the third extension, is it?
Yeah.
Not really, because we are relying largely on agency staff to deliver that.
It would affect 111 and digital services.
Hang on.
Thank you. Sorry, Chair.
Chris, were you? I couldn't hear you saying this. Too many
Sorry,
people.
so the 0845 service is entirely delivered by our agency partners. I think just picking up on the point, because we've touched on it through sickness, there's a strong trend of improvement through into September, so things like the warm transfers are continuing to increase, they're just below 94%. The substantive staff, health advisor and nurse advisor handle time is around 7:16 seconds for substantive nurses and around 5:16 seconds for substantive health advisors. And that the imminent changes are very unsettling for staff, but the staff themselves and the management team are continuing to make a positive contribution in terms of improvement. I do think that's worth noting.
And there's no circular effect in that those people that could have chosen redundancy if they were on non sick really may not have chosen redundancy.
I'm not sure I've understood the point, Steve.
The point is that we offered redundancy to people, some people took it, is that correct?
We didn't offer, people were in a position where redundancy was inevitable.
Right.
wasn't
Okay.
a-
So that wasn't a choice. So
No,
okay.
no, we
no.
didn't not offer
No,
redundancy
yeah.
to people on long-term sick where we might have done. No, it didn't work like that.
Okay.
Peter.
Well, I mean, I understand the sickness problem, and thank you for explaining it. But in terms of the overall sort of outside looking in, sort of that these average handling times, the actual fact that numbers have gone down to meet the plan, to meet our efficiency savings, I think shows that the job is being done, is being done well. And what's impressed me is that, because I do know in other places, these average handling times are not out of place. And in fact, they're not. And also, I mean, when you look at the national scene on callback in 10 minutes, we're not out of place there either.
Yeah, I think that was an important point.
But on both counts, I just wanted to. I think there's some positives in there.
Yeah.
I know I didn't just express the sickness rates, but I think just looking at it overall, and this is taking Joanne's point, that actually is quite a good set of metrics in my opinion. Now, if it's going to go out of line big time on sickness, then okay, that's different.
Sure.
But I do think on the national scene, those numbers of callback in 10 minutes show the weakness of all the providers currently, if that's a fair comment.
I was going to make a similar comment, so sort of outside the chair, but just generally, I think it's great, Chris, that I mean, operationally, we seem to be very much on track. That red one stands out like a sore thumb. And my suspicion would be that it's an artifact of the design of the new service, which after all is a new way of doing things at scale. The idea of one-stop shop and no callbacks, and that it's something that everyone is really struggling with. So it's obviously good to see it going in the right direction. Perhaps if everybody's struggling with that, then it's probably a system design issue more than it is a pure operational performance issue.
I think there is a system design issue which has been recognised by NHS England, which is that 100% warm transfer for those callers requiring to speak to a nurse is not attainable.
Yeah.
Not within any realistic resource bounds anyway. And the callback within 10 minutes is also unattainable. And that the follow-through is that they recognise that having a prioritisation system to ensure that those patients who don't get warm transferred to a nurse and don't get full callback in 10 minutes are the patients that are the least urgent. And that they are interested, NHS England are expressing an interest in the prioritisation system that traditionally we used in 0845 and which we've been using in 111 as and examining whether that's something that could be taken up by 111 more generally.
Because, just for clarity, the pure 111 model doesn't have a prioritisation built into it, because the assumption is that everybody gets warm transferred and anybody.
What it does in the sense that it's anybody who is requiring urgent streaming to 999 is not going to be warm transferred or call back in 10 minutes. So it does.
So of those who need to speak to a professional, Kat, can you tell us a bit more about that?
Just a point of clarity. There is a system of streaming the urgency of the callbacks, but that is a locally defined and locally determined setup based on DX codes.
Okay, excellent. All right. Thank you. All right. Are we? So I interrupted Jackie. So if these are still focusing on operational metrics, that's great. If not, we should move on. Yes. Okay. Louisa, then Steve.
And I was just asking about the transparency of other suppliers' organisational sort of scorecards. I mean, are they widely available?
Chris, Nick, Jackie.
I think the only one that we have access to is the one that we have in our pack from the national.
Out of interest,
comparisons.
the local health HOSCs or health overview scrutiny committees or whatever they're called do take an interest in those, because we did it in West Sussex. But I mean, that's the only way I know of getting formal information.
No.
I think I'm right
And
in
they're
saying.
bored.
I don't know what individual organisations do, but originally Department of Health, as was now NHS England, have a minimum data set which they collect on a monthly basis and which are publicly available and published on the DH or NHS England website on a monthly basis. Unless that has changed, then some fairly simple metrics are available for every provider published by NHS England.
Okay. That's useful to know.
Stephen?
Yeah, just out of interest, the 08 on the scorecard, the 0845 contingency. There's no figure for referrals to 999.
That's because we didn't set a target.
Right.
We can report what it is, but we are not pursuing it as a specific target.
Presumably it's less than the 111 service.
We'll report the data and give you an interpretation, Steve, but yes, that would be my understanding, that it would be less, but let's have the data rather than me guess.
Thank you. And continue on Louisa's point, and is that available to other suppliers, the 111 service? When I looked at that,
I think that it's part of the minimum data set that is published nationally. It's not on the data that we get courtesy of NHS London. But I think that's right, isn't that?
The 111, yes.
Yeah. So
I'd be interested in seeing that.
So we can draw that down off the NHS England website and distribute that to the board so you can see it.
I would find that interesting.
Yeah.
Thank you. Jackie, would you like to carry on?
So I wasn't going to say anything else on the scorecard.
Yeah.
I was going on to the financial report.
Okay. Is it anything else on operational metrics from the graphs or the scorecard? No. So, Jackie, thank you. Let's go on to money.
Okay. So on the money side, we have a 12.3 million year-to-date deficit. So sit quite comfortably with me. And that is an adverse 2.3 million variance against our research plan. And the key reason for that variance is because we are only getting cost per call for the 111 income from local commissioners, whereas the assumption made in the plan was that we would get our fixed costs covered for the year. I am still hopeful, though, that it won't have a negative impact on our forecast outturn if everything else carried on as it was going to be, of 26.2 million, because we do have some unspent monies from NHS England for the first quarter, which will be used to cover some of those fixed costs. But I've not taken those into account yet until I've reached agreement with NHS England on that. I'm still saying that the forecast outturn is 26.2 million. However, in the next couple of months, we'll be doing a more detailed piece of work on that once transfers to Ambulance Trust have taken place and we've got a little bit more clarity on what is going to happen. But at this stage, I'm not expecting any significant variance from that total. And I will be in close contact with the TVA to make sure that there are no surprises coming up on our side. Cash management is remains an issue for the trust, as we have to run down our balances before we're allowed to access any of the cash. However, I don't believe that this is a risk to us not being able to pay staff or key bills. We just have to make sure that we keep on top of the cash balances as they go downwards. And that's about all I was going to cover, unless anybody has any questions.
Questions for Jackie on the finance? Peter?
Just a couple of comments. I've had a long chat with Jackie, so it's been very helpful. I think given the uncertainties, particularly with the smaller commissioners, the 111 commissioners who are playing around a bit, I think what's in front of us is as sound as it can get. My concern, as I said to Jackie, is that if we do not meet those due dates for transfer, this problem of the gap, if I can call it, with commissioners will get wider and wider, and we don't really want that. Now, obviously we're going to meet the due dates, I'm sure, but that is a factor. I do think cash flow, I know you're managing it well, but it just reminded me that we can't claim the decommissioning money until we've spent it.
No.
And therefore, if we don't get the cash coming in from other sources, other than your back, that reserve, as it were, then it is a problem. So that does need some, quite strong vigilance to keep that on board. And the only other thing I just wanted to mention is the profiling. I'm not sure how important this is, but I think we as a board just should be clear about the fact there has been a reprofiling of the budget, and therefore the way in which we will see the income and expenditure will be slightly different to the base agreement that we've got on the budget. I don't know if you wanted to comment on that, but I do think we should understand what the implications are.
Yeah, certainly, we've reprofiled our budget since we submitted it to the TDA, largely because some things were becoming more certain about when they would come in. And I didn't want there to be lots of different variances on different lines just because the timings have changed. However, I'm aware that when I submit something to the TDA, I'm also having to sign off that I'm reporting the same, exactly the same to the board. Yeah. So I'm just reporting here that there is a difference, and equally the TDA get this report too. I'm hoping that for next month we will have resubmitted the profile for the TDA, so that will be exactly the same.
Thank you.
Thanks, Jackie. Nick, and then I'd like to make a comment.
Could I just pick up on Peter's point about income from commissioners, essentially? I think that it's very important that we have an absolute clarity as a board about the things that are within our control to manage, and all of our costs are within our control to manage, and we have an obligation on behalf of the system as a whole to manage those prudently, which on the one side is making sure that we don't run into problems of quality or safety because we're somehow letting our cost agenda get out of hand, and nor can we be wasteful of costs, and it is within our control to manage our costs. And I think that will come into quite close, we need to keep very close on that cost agenda throughout the remainder of this financial year, even assuming that transfers go ahead. In contrast though, our ability to manage the flow of income is virtually zero. The fact is that we are reliant upon agreements between local commissioners and NHS England about who will bear what element of cost from a commissioning point of view, and that moves about, and there is also the balance between the costs that the TDA pick up and those that NHS England pick up, even though they come from the same vote in Parliament. Seemingly which pocket of money they come from remains important, and we're not in control of those things. And I think it's really important that as a board we keep clear those things that are within our control to manage, and those things that we are reporting as variances as a result of decisions taken by the people.
Correct.
Yes. I think it's very helpful. And we need to make sure that we're not asking, implying that we're asking Jackie to do stuff that isn't just.
It is not within our control. Absolutely.
Tim.
Jackie, I'm not asking you to do some mental arithmetic straight away, but let's say that all the transfers move by a month. Could you just let us know what that would do to the deficit? Or maybe the two big ones?
Yeah, I don't think it will make much difference, to be honest, Tim, because the forecast outturn, if no transfers take place, is 26 million. Forecast outturn, if they all take place when they're supposed to, is about 25 million.
So there's little
impact
really of that, because I think that's the big risk that we've got, that we won't be able to make the transfers on time. And I know you're working really hard at that, but I'm surprised the financial effect is so little, but thank you.
Can I respond to that?
Yeah, quickly.
It's because we have to maintain our fixed infrastructure. We are not dismantling it in anticipation of transfers happening in November, because we are being told by the system, don't do that.
Yep. Okay,
That's
thank you.
the reason.
So the high fixed costs are not changing. Thank you.
So the point that I was wondering about, Jackie, was around the cash flow.
Yeah.
And just the way it's reported in Appendix 3.
Mm-hmm.
I mean, given that managing cash flow is going to, it's obviously a focus of your attention. It's going to be really important right up to the end of the financial year. I just wondered whether the board might be able to see, have a longitudinal view of what you think the cash position is going to be from now till the end of the year in some sort of summary form. I don't think we need all of these.
Yeah.
And then we can look at what's happening against that, because otherwise I think the board hasn't got enough sight.
Yeah. Basically, the cash goes down and then we get some more, and then it goes up again. So we always have enough to pay our bills. So I'm not sure it will necessarily show you very much, but
No,
I'll be able to determine. I can show you something which says when we run out of cash each time, then we just get some more in.
I accept that.
Yeah.
But I think that from the board's point of view, it's just a little bit uncomfortable looking
Yeah.
at a single
Okay.
month of retrospective cash flow,
Yeah.
given that managing cash is such an important thing.
Yeah. I'll do that.
Although I take your point, I wouldn't expect to see anything, any sort of particular insight that we haven't already got from it. Okay. Anything else on the finance package? No. Lovely. Okay. Thank you very much, Jackie. I think as a board we are. I'm going to suggest from what I'm hearing and what I'm seeing around the table that the board recognises that this is difficult and has a very high degree of confidence in the way that it's being managed. So thank you. All right. Reach over. We don't have anything in our strategy section today, so we're going straight from performance into the governance and compliance section of the agenda. And Alan is going to talk us through the board assurance framework and the risk register.
Thank you very much, Chairman. So the report is there at item 8. By way of introduction, just to bring the board up to date on movement since July when this was last considered, we've now received and reviewed the risk registers from all the corporate directorates, and I'm content that all of the high risks that are highlighted in the individual risk registers are now reflected in the BAF against one or several of the key corporate objectives for the year. We've also completed the training programme for our risk leads, so that there's now I think greater uniformity in approach and in the way in which the risk registers are being maintained by the individual directorates. And we're now in the process of establishing a risk leads group, so that each month there can be some peer review of individual risk registers and some hopefully some greater consistency in the approach than we so far have. In the covering paper this time, rather than simply summarising how the BAF document looks, and I think I also take your point about having a version for visually impaired, because I struggle with the size of the font on the appendix. So what I've tried to do in the summary is draw attention both to those areas against each of the 5 main corporate objectives where we have, I think, both significant assurance and a degree of comfort and reliability in the data that leads to that. But also, I think more especially those areas where assurance is limited. And without wishing to repeat a lot of the discussion that's already happened during the course of this meeting, I will just quickly summarise that against the first objective of delivering our services well, for 111 services, the point that we've already reached in terms of the importance of meeting the transfer dates is highlighted in the BAF as a key risk area. And as Nick has suggested, that's one of the areas which, although we can influence, we don't have the full control over that process. The volatility of 0845 has been mentioned, and that's also captured here, and the impact that relatively small changes in staff numbers could have on performance. And as far as the digital services are concerned, the key risk at the moment, we believe, is essentially being able to demonstrate the value of those services when volumes of activity are so far below the commissioned levels, and a lot of work is going on in conjunction with other providers to try and bring volumes up. As far as clinical quality and safety is concerned, the big risk highlighted there is related to staffing, and we've already had a conversation about both staffing numbers and maintaining morale, and of course we need that to be high in order to continue to deliver a reliable and safe service. And finally, as far as finance is concerned, we've discussed the 111 service income levels and their volatility and the impact that could have on our achieving our revised budget target. Although the impact financially of delays in the transfers is minimal, as Jackie has just said, I think the biggest risk there, as we've already considered, is on maintaining staffing numbers to deliver the service beyond the period of the transfers, if that should occur, particularly given that we're entering the winter period towards the end of November. And I think the final point on the financial risks is the need to continue to manage the decommissioning costs within the sums that have already been approved by NHS England several months ago. So that was really all I was going to say by way of summarising the BAF statement. The only other final reference I was going to make was that another item on the agenda, when we look at the internal audit reports, does report a recent review of our risk management process, where substantial assurance has been given so far. So I think that's quite reassuring that the auditors have looked at what we're doing and are quite happy with it.
Thank you, Alan. Are there any questions? Other questions on the board assurance framework today? That's a very comprehensive run through. Thank you. All right. That was good. Thank you. Let's move on then to the minutes and feedback from committees. So let's remind ourselves of what we've got. We've got a finance committee that was held on the 11th of September, and we've had a bit of time here, so we've got the meetings taking place and we've got the minutes together. Tim, do you want to highlight anything?
No, I'll take them as read actually and answer any questions.
Are there any questions to Tim on the minutes of the finance meeting?
I think we've repeated the discussion already on the finances. We've covered the same issues.
Thank you. And I think there's probably something coming up in the private section on
yes,
contracts.
There will be.
Okay. Sue, you've had a clinical governance meeting on the 20th of September, so we've got verbal feedback from you rather than minutes. Yeah?
Yep. Okay. Clinical Governance Committee. The committee seeks assurance that our clinical governance processes and systems and resources are sufficient to ensure that that we provide a safe, clinically effective and high quality service to our patients. And we do that through the committee by considering a whole raft of items. This month we had a fairly detailed debate around the clinical KPIs, a lot of which we've already actually covered already in the committee, in the meeting today. And really, the key message from that is really the one that Tricia's already given, which is actually there's a recognition that there are areas that need to improve in terms of the clinical KPIs, but that progress is already being made and that there will be continuing focus on improving those clinical KPIs, in particular the warm transfer, which we've already talked about and has already improved significantly, the call reviews and the complaints review processes. We look in detail at the clinical risk register, and Alan's already picked up sort of key clinical risks that we've discussed in the meeting already. There was a thematic review of the last 6 months of serious incidents to understand whether there are points of learning we need to take from those reviews. We receive information about the patient feedback across the 3 services, the 0845 service, DHAS and the 111 service, and all of those results are very encouraging, although there is a need for higher sampling rates across some of the services. We received a report on the clinical research programme and the key learning points from that. And the final item was staff feedback from the listening exercises that are ongoing at the moment, and that's provided some very useful first impressions and ideas about areas that we can improve our clinical governance processes in, and much broader issues around quality and safety. And the committee is looking forward to receiving that final report at the next meeting. I think that's about summary. Tricia, is there anything there that you would? That's everything. Yeah.
That was a very nice summary, Sue. Reminding us also about what the Clinical Governance Committee is actually there to do. So thank you for that. Very good. Questions for Sue? Any questions? Okay. Thank you. That concludes the governance and compliance section. So while I remember for the tech guys at the back, we seem to have a slightly odd echo on this side of the table when people are speaking. I don't know if that's unusual. I don't know if anything could be done about that.
It does remind us that we're speaking in public, though.
Yeah.
Sometimes by time. Of course we don't.
Thank you. Next part of our agenda is looks outwards towards our stakeholders, both our staff and our patients, and sometimes our commissioners. If we can begin today by talking about conversations that we've been having about with our staff, particularly those focused on the post-Francis report listening events, which, as colleagues will remember, have been mandated for all NHS trusts and foundation trusts, just to make sure we really listen to and hear what our frontline staff have to tell us about their ability to provide a high quality, respectful, safe service to patients. Tricia, a whole programme of these events have been taking place. Would you like to just give us some context, and then maybe we can hear from some of the people who've been doing it?
Yes, certainly. Thanks, Chair. So we all remember the Francis report arising out of the mid-staff events, and the encouragement for the board and executives to go out and meet frontline staff and hear for themselves how staff believe they are delivering services, whether they are of good quality or where improvements can be made. And our comms team, thank you Anna and her colleagues, have helped us facilitate executive visits and on occasions those supported by non-execs across the country. The staff are really pleased to be engaging with senior members of the organisation and to share their experiences of the significant changes in service delivery to patients over the last 3 months or more. The key issues that are being raised from these events, because we are particularly focusing on the key questions are: do we believe we deliver a good service to patients? Do we believe they are safe and of good quality? And if not, how can we improve them? And what are the barriers to stop individuals actually addressing those gaps or those needs for improvement themselves? One of the key focuses has been the use of pathways within our NHS 111 service, and there are very mixed views. The frontline staff, the health advisors particularly, like using pathways and feel that they have a greater opportunity to deliver and conclude patient care. There are key elements of frustration around DOS, which is the Directory of Services, which is almost the database, the telephone directory of services where patients can be referred to. And as you would expect in any new service, there were teething problems in the very early days. Staff are reporting that there are seen some improvements within that, but inevitably in some of the out of hours areas, particularly around dentistry and the dental service provision, there Tim's taking a shout and take a breath due to some other issues. There are concerns that there are not services available to refer patients into, and sometimes the journey is onerous, for our staff to get the patient to the right place and the most appropriate place for them to receive their care. The nurses, they equally enjoy using pathways, their frustrations are, their perception is the content within Pathways does not support them as well as they would like, and on occasion they also believe sometimes the validation of some of the calls is unnecessary, and perhaps our health advisors could be supported further within the Pathways content to actually conclude and close those calls. And I've given that feedback back to Pathways, and also helped address some of our staff with some learning issues, and equally fed it back into the training materials so our staff can address those issues. Overall, the staff understand the changes that are happening within the organisation and the reasons why we are transferring those our NHS 111 services over to Ambulance Trust, and they are equally as passionate as every person around this table is ensuring that we maintain and continue to deliver a good, safe, quality service to patients during these continued changes that they're experiencing. As a consequence of those changes, it's inevitable in these listening events, staff do bring their individual concerns about their future, continued employment, etc. And it's been a great opportunity for us as executives to be able to give very clear and message directly to those staff who are involved, though obviously we've been giving extensive and clear communications through all our other channels. There is nothing quite like having an exec in the room and asking the questions and getting the answers directly.
Thanks, Trisha. Steve, did you have a question or comment?
Well, there's been a few comments over the last couple of meetings about Pathways and either not responding to changes we want them to make, or I think you made a point that some clinical staff are saying it doesn't support them sufficiently. I mean, I'd be interested from Kat and Tim to hear what you think of Pathways. I mean, is it fit for purpose? I mean, I guess it must be, otherwise we wouldn't be using it. But there does seem to be some concern over it as a tool.
I guess my exposure to Pathways is perhaps slightly more extensive than the next person's, because I've sat on the National Clinical Pathways Governance Group for 3 years now. The two big advantages I see behind Pathways are the governance structure, which involves every Royal College that there is, and every pathway that's developed and every change to every pathway has to be okayed by every Royal College. And second of all, the foundation also includes a thorough assessment of current evidence and is updated on the basis of evidence which comes out from SIGN, NICE, etc. and so forth. So whilst I think there was an issue with the requests for change and the speed by which they were picked up and pathways were altered, I feel that system is more responsive now. But in terms of the foundations, both from a governance point of view and an evidence point of view, I am very confident behind Pathways.
Tim, did you want to add anything to that?
I don't think I've got anything really to add beyond observing Pathways in use does seem to deliver sensible outcomes.
Okay.
Can I pitch in terms of just a very brief reflection back on the visits that I've done? I've done 3. And I've enjoyed them. I mean, clearly that wasn't the objective, but it's a good outcome from my point of view. But I think what it does reflect is that the way in which we're approaching these and also the way in which frontline staff are approaching these is we're getting it right. So I'm having discussions with groups of staff in 2s and 3s usually. This isn't a big sort of get everyone offline and pile everyone into a big room and have one conversation. This is very much talking 1-to-1, 1-to-2, 1-to-3. And staff are very open. They are very concerned about the great degree of change that's going on, and as Tricia said, a lot of conversations are about what does this mean and what is happening first of all, and then what does it mean and what does it mean for me. But I think overwhelmingly, when we come back to the question, are we a caring and compassionate organisation so far as our patients are concerned? Is there evidence in the way that we approach our provision of service to patients that says that that it really matters what we do, or are we somehow letting that slip? And whether you talk to agency members of staff, or to newly arrived members of staff, or to staff who've been with NHS Direct for a decade or more, really almost every single person says, I constantly get reminded about the need for providing a good, safe service to patients, and there are lots of things that happen to me in my daily working life that remind me of that. So I think in terms of getting reassurance that we're not in charge of an organisation that is actually off providing services in a wild and reckless kind of way that is not focused on our patients, we should feel reasonably reassured.
Okay, and Nick, as part of that, I mean, one of the critical sort of learnings that I think are intended from those visits is to make sure that we haven't got a situation where the board is out of touch with what is going on in our delivery sites, nor that we have frontline staff feeling that their ability to provide the care that they want is hampered by a lack of resource, and it seems to me from what I've been hearing that that's not what we're doing here. Okay, good. I think it's very important, and it demonstrates, I suppose, that we are that we're getting from these visits that which the programme of visits was intended to do. Okay, thank you. Tim.
Can I just add to that a non-clinical point? But when I went to Nottingham, I was delighted, well not delighted, but reassured to see that the supervision had taken very sensible actions, like concentrating people in one room and leaving another room empty, instead of having sparsely populated desks, one desk occupied and then 3 desks and then somebody else, which is a terrible sort of work environment to come into. So the evidence that I drew from that is that the supervision are doing those quite simple management things to help that happen. So that was in Nottingham, but I'm sure it's happening elsewhere, which I was reassured by.
That's great. And just one final point from me about coverage. So are we going to be in a situation where every single site will have had a visit?
Yes, at least one visit, if not 2. That's by a different executive. So, for example, Nick's been to Carlisle, I go back to Carlisle later on this month.
Good.
I'd quite like to go to Carlisle permanently. I thought it was delightful. But
that's not day out in Carlisle.
Oh, thank you. I think then we can move on to the call recordings that were prepared for us this month. Has anyone not been able to listen to the call recordings? Is that Sue?
I think
you didn't get the CD? Okay, well, let's chase that. I mean, we know that they're encrypted, so even if it went astray, we don't have a confidentiality problem. So everyone else around the table has had the opportunity. That's really good. That's very nice. Thank you.
They were very quiet.
Trisha, we've had a chance to read the introductory paper and get the context as well as the course. So I think unless you want to draw our attention to anything in particular, maybe you could just very briefly summarise what it is we're listening to, and then we can have a conversation around one and then the next.
Okay, so this is the DHAS, which is a digital health and advice service call. This is a 43-year-old lady who's used our health and symptom trackers online and self-assessed herself for insect bites which she sustained to her hands, and through that assessment triggered a response which invited her to request a call back from a registered nurse, and that's what took place. So the call has entered an automatic electronic queuing system with the patient details, and one of our registered nurses has picked that call up and called the patient back and undertaken a more in-detailed assessment of the symptoms, and then given advice. Further comments on the advice things given, or I shall hold my counsel until.
Why do you hold on, Trisha? Because Steve's got.
Well, I mean, my question was a process question, really. It's about the safety of the call. It says taking the past medical history at the outset to delay ruling out the identification of immediate life-threatening conditions. Isn't this a process within pathways?
So this isn't a pathway
No,
call,
it's
is it?
not.
Okay.
Yeah.
This was a symptom check.
Oh, of course it was. So it didn't go through the pathways system. No.
So Trisha, that's supported by teleguides.
Yeah, it's
Nick
supported
told
by
me.
teleguides, and the principal, the the comment that's being made within the report is most clinicians seek that the patient is safe and there is no emergency symptoms in their first engagement with the patient. However, one of the comments within this assessment was the nurse asked past medical history at the beginning of the call, and previous feedback within the organisation is past medical history really should only be sought and clarified if it has an impact on the presenting symptoms, and we didn't believe in this call it was relevant or appropriate to ask those questions at the beginning.
Tim, you got a comment on that?
Well, I was, I guess, puzzled a little bit by that comment, what was written and what I heard, and that does the online system not pick up the urgency?
Yeah.
I mean, that's where it should be done.
Yeah.
And by the time you're clicking to call back, it is for advice, not for urgent.
Correct. That's exactly
Dispatch
right.
ambulance. And so I thought that wasn't unreasonable if the nurse felt comfortable sort of contextualising and perhaps giving her time to think a little bit about the problem while she asked them the routine and mundane issues.
I agree with that, Tim. I thought it didn't impede the conversation. I think it enhanced it. I think it helped the nurse actually gain the rapport. In the summary statement, she was formalising in the initial engagement with the patient, and just to clarify, there's no past medical history.
Could I? I'd really like to understand the process here. So, in paragraph 2.2, where the concerns are noted, is that something that had already been done for this call before it came to us?
Yes.
Because does that imply, so that implies to me, that first bullet point, that whoever reviewed that call and made those comments has an expectation that a click to call back includes the sort of safety questions that you would have if somebody had called you on the phone. And I'm just not sure that that's what we should be doing. So what's the next step from this? Because if we've got people reviewing calls who have a different view about what we're trying to do when in a click to callback situation, is that not a systemic process problem?
We're coaching people in the wrong
direction.
Yeah.
So what will we do about that, Tricia?
Well, we will feed back this, the comments back to the head of clinical DHAS services, and obviously cascade those messages, as well as do give the feedback to the people who are doing the call reviews, as well as the training of the people doing call.
Because it does sound a bit like a hangover to a very risk averse and bringing a mindset which treats somebody who's already been through an electronic symptom checker as though they were calling, out of the ether and could be, not breathing or bleeding all over the place, when we know that's not true. And that, I think, is a shame, really. Okay. Any, Alan and Kat?
Just one supplementary on that. I felt there were a couple of hangovers of slightly different sort. The nurse said, "I'm returning your call," and slight disconnect with where the referral had actually come from. And then there was a reference at the end to the GP out of hours number potentially being provided if the patient called their GP, which actually would probably now give them 111 number. And so it just felt to me like maybe there's sort of building on what Joanne was saying earlier, there's maybe a need to sort of just review that whole context and say, are we sort of end-to-end providing the right sort of context for our nurses to deliver the service?
Thank you, Alan. Kat?
I just need to point out there's a slight inaccuracy in terms of the information that was given, which was that all antihistamines are the same. And they're not. And there was a slightly unhelpful comment about, well, the doctor will start you on antibiotics, which will make it better, which perhaps wasn't so helpful in terms of patients seeking health-seeking behaviour. And just ashamed that at the end, despite the disposal coming out as a GP the next day, that was in fact overruled, and a higher acuity disposal was actually given.
But what higher?
Walking.
a higher acuity. So
Yeah.
the call taker ended up saying, well, of course you can go along to the walk-in centres today, kind of thing.
Yep.
Okay, so what do we do about things like the antihistamine? I mean, that should be presumably in the teleguide. Because I think there are a couple of issues around that, and the fact that with some antihistamines, drowsiness is a huge issue, and if you're telling people to drive off to a walk-in centre. So what's our next steps out of that? Should that teleguide be reviewed, or what should happen, Kat? Because we don't want to leave it, I think, hanging.
And I suspect it needs looking into, but I suspect it was an interpretation of perhaps a generic comment within the teleguide. So I think we need to go back and run through the teleguide ourselves and just double check the wording and make sure that it's not something that has a potential to happen again.
Okay, thank you. Great. What I think about this, in summary, my opinion, rather than the chair's opinion, is that this, I very much agree with the point about, well, maybe we haven't quite modernised that bit of the process to reflect what a clinical callback really is about. I think that those issues are interesting and are well worth looking into. I think, even more broadly, it's another example where issues that we pick up issues as non-specialists on the whole that haven't been picked up in the core reviews. So that whether our core reviews are rigorous enough is, I think, a theme which recurs through this, and one that I don't have a solution to, but I think we need to continue to be aware of and be thinking about, perhaps through the Clinical Governance Committee, how we make our core reviews sufficiently consistent, rigorous, demanding, so that we can support our staff to really improve on an ongoing basis. Because saying something's fine when it's not, it just isn't, it's letting our staff down as well as our patients.
Can I add a sort of twist to that slightly, which is that, and I think it's very clear in the way that this core review has been written, which is that the context for the people writing this paper is reviewing the practice of an individual nurse or health advisor, rather than taking a step back and saying, what might we learn about this call and how it's approached more generally, not coaching points for the individual. And I think that it would be useful if we could reorientate this so that there's an element to do with the practice of the individual, but the other is really looking at how this thing is being delivered and what are the broader points that we should learn from it.
Yeah,
but just to note that this core review didn't pick up the point about the antihistamines, which perhaps you would have expected it to.
Okay, thank you. Shall we? I think it's good that we're as picky as we are, by the way, in this forum, because we're looking for better, always better. Shall we then look at the other one, Tricia?
I actually didn't have the report for the other one, Chair. I'm sorry,
Okay.
I've only got the wrong file.
Nick, would you like to just...
Ooh, that's putting me on the spot.
Well,
This is, no, I can do this. I can do this. I listened to it this morning. So this is a call from a first-time mum of a 2-year-old child who had a history of earache, fever, and lethargy and sleepiness. It was a call that lasted, I think, 14 minutes.
That was just the health
sorry, that was just the health advisor bit.
24.
Yeah, 24 including the nurse. It was quite interesting in that there were quite long gaps when, in my interpretation...
I'm going to ask you to say, to hold your person.
Oh, fine. Okay, so this is
the context. Fine. So we want to hear them, but maybe not first.
I've given you the context, which is, I think, this is a 2-year-old phoning up the 111 service, speaking first to a health advisor and then subsequently to a nurse.
Okay. Does anyone else want to make any comments about that set of calls before we invite Nick?
Yeah,
to
I'm very happy not to.
Peter, do you want to say something quickly?
Just, you mean about what I thought of it?
Yeah, what you thought of it,
oh,
exactly.
Right,
what
okay.
you thought of it.
Well, the first element of the call took, because I was consciously now thinking, well, how long is it going to take to get to the point where you ask, well, what's the problem, as it were? And it was 3 minutes in for the demographics, and then we began to, get to the nuts and bolts, as it were. So, I mean, it just shows me that, all of that stuff comes in front of anything concrete, shall we say, for the person coming. I thought the health advisor was actually very good. I related to her, and I thought that her style and approach was excellent. As you were going on to say, I think, though, it was slightly awkward when she said, "I'm going to put you on hold," when I thought she'd gone away. So, I mean, all of that good stuff was slightly, but it is mentioned in the report, so it was picked up. And I mean, there does need to be something to ensure the person hangs around to carry on after they're put on hold. Anything else? Yes, she kept. I don't know. Nice touch for the health advisor was she said, "I'm going now to move on to asking you some assessment questions," and then she went on to say, "And now I've got to where I've got to. I'm going to ask you some questions about pain in the ear," which I thought was, was quite nice. And so the person knew where they stood. I thought, even though it did take a long time to get there. I had some comments on the nurse, but
this is the health advisor for the moment. Thank you, Peter. I don't know if any of our clinical colleagues want to comment about that. Tim?
I just observed that I think that the outcome was very nice. I thought that's what the service is here for. We're delivering it in a systematic manner. However, the process and the bioethics and all that is just much too long to make it a commercial proposition. That was my feeling. But I very much liked what it was doing and how it, where it got to. And clearly, from the comment in the written papers, the patient was extremely happy to. The mother was extremely happy to.
Nick and I had a little, we listened to it together, and had a little interaction around it, where I commented on the repetition within the call. So she had to say 4 times how long the fever had lasted, and Nick said, well, that's good, isn't it? Because she talked it through and that made her anxiety.
So it might be good. I mean, So my perspective was, here is a mum who's obviously been worrying about her small child, and is actually very happy to talk to people about it. And the fact that to us it may seem like a long time, actually she was clearly very pleased to be able to talk it through. And had she had an efficient and short call that led her to snappy, clear advice, it may not have quite hit the spot with her.
But so my response to that is, that's what we tell ourselves. But that's what we like to think, because that's the way we do it. And actually, if we were a consumer company, we would know a lot more about what's good. We'd have our segmentation, and we would know. And so I think we comfort ourselves with, she probably loved it because she told us she's satisfied. And actually, we know there's an optimism bias in patient surveys. People are very grateful for what they get. So I think maybe we're not self-critical enough. Kat?
I just want to point out, I mean, trying to telephone triage little ones on the phone is often a complete nightmare. And this call really kind of brought that to home because of the conflicting information that the caller gave about the fluids and so on. It's a really complex and difficult case to be able, or set of patients to be able to do well. I think that it was a wee bit stilted and there were a couple of, fairly long pauses, but the effect of those pauses were that the correct pathway was ultimately chosen, and still, at least from the kind of the verbal sounding of the caller, she still had rapport with the call taker at the end of it. So that was my take on the call handler part of it.
So let's talk about the nurse bit. Has anybody got comments on the nurse?
Can I make a last point about just the jargon on handover? I'm now going to pass you over for quotes. Home care management advice. And I just thought that the rounding off of the conversation, and it's clearly how it's referred to in the system, and therefore the prompt coming to health advisor, but user-friendly it is not. So I think there could have been a rounding off of that, which is I'm now going to pass you over to a nurse who's going to check that you've got the advice you need to help care for your daughter.
I did just want to go just to back up that signposting. Is that I think it's the
first call I'd ever heard here, really, where there was clear signposting, where she said, I'm going to do this, and talked her through, well, which pathway am I going to choose for you? You know, am I going to choose this or am I going to choose that? And having said that, I thought that I think that there was a lot of repetition, and I mean, clearly nobody could see in this little girl's ear, but somehow we can sort of seem to get over and move on from that.
Yeah, so I'm going to exercise chair's prerogative and come in again and say I very much agree with Kat. I think that my overall impression, I suppose, was here's a call handler who perhaps isn't terribly experienced at using this pathway system, and therefore was a bit slow and a bit repetitive, but had the makings of a brilliant, a brilliant call handler because of that rapport, because of that innate sort of structure, and I'll tell you what I'm doing. And I thought that was fantastic. I hadn't quite got there, but again, that's why good call review and good coaching is so important, because it will take our good staff to a point of being really excellent, which is a nice segue into the nurse. Anybody wants to talk about the nurse? All right, I mean,
I don't mind. I'll start again.
Go, yeah.
Well, I mean, the nurse had a nice tone to her. I really liked the calm, cool stuff that how she came over anyway. But she was dealing with quite a calm mother, I thought, as well, which I don't, quite. She wasn't panicking. I think she was very good. Two things, I suppose, about it. I mean, it did go on a bit, and the thing that I thought was good was she told the mother, "You're doing all the right things." I thought that was really a helpful statement to make, and I thought, great. But then, a little later on, she described what the child didn't have. She started to tell her, well, you're lucky, he hasn't got this, hasn't got that, hasn't got the other. And I thought, well, that's undone almost, the saying he's doing all the right things. So although she was reassuring in the way of doing that, I didn't think she needed to do any of that. I think when she was saying you're doing all the right things, we come to the right conclusion, and you can be happy to go on your way, as it were. And if you want to come back to me, please do.
So that's a really interesting point, Peter, because I had a very different reaction to that.
Did you?
I mean, I thought that the call wasn't very long. It was about 5 minutes or 8 minutes or something.
1700.
Yeah.
Oh, maybe I thought more.
I think it was from 17 to 24 minutes. So,
okay.
I mean, it's really 7 minutes
8
long.
minutes,
I thought all the positive things that you thought. I also particularly liked the fact that the nurse talked about, with dehydration, what we look for is sunken eyes, dry mouth. Because I felt that she was empowering a mother who was quite calm, and maybe it wouldn't have worked with somebody who was very anxious. And she was empowering that mother to know how to make a good decision in the future, and I really, really like that. So that's a judgment thing. I don't know what anyone else felt about it. Kat?
I mean, just all of the above, and the only thing that I had to try and find something to improve on next time was the fact that no time frame was given at the end by which the mother should call back again or seek some other help. That's the only one thing.
Especially with a dry nappy. Lisa?
It struck me that actually we don't know, do we? So it's interesting that we have such different opinions, and actually why, in a funny sort of way, you need to, only your users can tell you that. So although we have this list, maybe they're not the right questions, or maybe we need some more qualitative, in-depth things to find out. I think that's really, really important.
It's different points, but on the nurse, which is a procedural one, it's not a comment on what the nurse did, but what we asked the nurse to do, which is the warm transfer details. And do we really need to have so many personalised items for the transfer? I have to say, just to tie it up with when I went to Bristol, there were 5 of our nurses there, and they had written out for me their concern that we were in making them go through a process of repeating demographic information ad nauseam on warm transfer, that it was unnecessary for the patient. It removed the rapport that they had with the patient right at the start of the call, and they really, really, really wanted to stop doing it. Why do we not have a more slimline version to make sure that the warm transfer hasn't somehow provided an alternative patient in the process, and that a simple "am I talking to Mr. Smith" would do? So that was, I just lodged that, not for us to come to a view as as a committee, because I don't think that would be appropriate, but just to lodge it, I think it's something we should look at.
Is that a pathway thing or a choice from NHS Direct thing?
It's an information governance thing. It's to check that he's speaking to the right patient. I think there are issues that we can address as what information and how it's formulated and responded back to the patient, but I'll take
Is
it
it
away.
our information governance?
No, it's a standard which you have to check 3 aspects of patient identifiable information to make sure you've got the correct medical record.
And does that change if you call somebody back or if it's a warm transfer? Is it the same?
It's
because that just doesn't seem logical, does it? Anyway, that's fine. You don't have to defend that.
I mean, I on that very point, it is absolutely required if it's callback.
Yep.
But I think to review that in the context of a warm transferred call, where there is a direct handover, I would think it's entirely appropriate to review it and consider what the minimum might be.
We don't want to get into a health and safety banning conkers situation, which I feel we may be.
Can I make just one other point? I did notice that the nurse appeared to make a couple of errors in their sort of read back from the information that they will have received about the prior consultation that had taken place with the health advisor. Comment about, I think, the ear being read on the outside rather than, and it just seems to me that it's really important for them to, and I can imagine it's quite difficult because they've just pulled the record up in front of them and they're talking and reading at the same time, but I think if I were having that fed back to me, I'd be quite irritated if somebody made a couple of errors. No, I've just told the person it was, that they saw the doctor and they reported inner ear redness, and to have that reflected back wrong would be quite disconcerting.
Yes, that's a fair point. Thank you, everyone. Thanks, Tricia, to your colleagues for putting those together for us. I've let that conversation go on. I've really valued the fact that we were able to spend some time talking about patient experience. It was great that everybody heard the calls. Tricia, can we have a conversation offline about what comes next time? And I'd like to move just very quickly on to any other business. Any other business, anyone? No? Next time we meet will be on the 28th of October at 10:30 here and online. I'm going to suggest we have a very short break and we reconvene in private at midday. Thank you very much, technical support, and that brings our meeting to an end in public. Thanks a lot.